afternoon. Thank you so much for joining us today as we discuss the recently released Cancer Treatment and Survivorship Facts and Figures. My name is Carol DeSantis, and I'm an epidemiologist with the Surveillance and Health Services Research Group. Today, I will give a brief introduction to the report and discuss the popular cancer survivor estimates. Next up will be Ted Gansler, Director of Medical Content for the American Cancer Society, and also an editor of CA, a cancer journal for clinicians. Dr. Gansler will be sharing his clinical perspective on treatment patterns and survival for 4 of the 12 cancer types provided in the report. And finally, we will hear from Dr. Kevin Stein, Managing Director of the Behavioral Research Center. Dr. Stein will be discussing survivorship and quality of life issues. Survivorship Facts and Figures is the most recent addition to our lineup of Facts and Figures publications and is a collaboration between the Society's Surveillance and Health Services Research Group and the Behavioral Research Center. In addition, many other staff at ACS, as well as external content experts and our National Cancer Institute partners, contributed to and were involved in the production of the report. This is the second edition of our Cancer Treatment and Survivorship Facts and Figures, and the publication is updated every other year. As we do for many of our other Facts and Figures publications, we published a companion article in the CA Journal. This article provides additional statistics and information and targets the clinical and research audience. One of the most cited pieces of information contained in this report are prevalence estimates. That is the estimated number of cancer survivors living in the U.S. in the current year and the expected number 10 years from now. These estimates are produced in collaboration with the National Cancer Institute. Previously, we used NCI's more directly estimated cancer prevalence estimates that lagged several years behind the current year. With this new projection method, we are able to provide estimates for the current year and 10 years ahead. However, because they are produced every other year, they do stay the same over a 2-year period. Just briefly, the prevalence estimates are projected using a statistical model that incorporates data on cancer incidence and survival from NCI's SEER cancer registries and all-cause mortality from the National Center for Health Statistics, as well as population projections from the U.S. Census Bureau. In the report, we document the continued growth of the population of cancer survivors. As of January 1st, 2014, there were 14.5 million cancer survivors living in the U.S., including nearly 6.9 million males and 7.6 million females. We expect that total number to grow to almost 19 million over the next decade. There are 2 factors really driving this growth of the survivor population. First, the U.S. population as a whole is growing and getting older, and cancer is more common among older adults. And second, improvements in early detection and treatment have meant that people are living longer with cancer. Here you will see estimates for the 10 most common cancers among male and female survivors in 2014 and 2024. By far, the most common cancer among male survivors is prostate cancer, followed by colorectal cancer and melanoma. Among female survivors, breast cancer is most common, followed by uterine and colorectal cancers. In the report, we also provide prevalence estimates by age of diagnosis and by year since diagnosis. For example, nearly half of survivors are ages 70 and older, while only 5% are under the age of 40. 64% of cancer survivors were diagnosed 5 or more years ago, including 15% that were diagnosed 20 or more years ago. Now, at this point, I'm going to hand it over to Dr. Gansler to discuss cancer treatment patterns and survival.
My goal for the next 10 minutes is to introduce the treatment and survival information in Cancer Treatment and Survivorship Facts and Figures, also known as CTSFF. It would take hours to discuss all of the facts and figures in that document, so my section of the webinar will be a brief preview of the kind of information you can find there and an explanation of why this information is so important. The point of treatment is to have a positive effect on length and quality of life. However, treatments can also cause adverse long-term and late effects. So knowing which treatments are used for various types of cancer can help you to anticipate many of the problems survivors will encounter. Although it's difficult to make conclusions about quality of care based on aggregated data, I'll show you a couple of examples in which researchers start with this information and then focus in on smaller populations to assess quality of care and the extent to which equity or disparities are present regarding treatment patterns. Keep in mind that these are highly aggregated observations and are not intended as treatment recommendations or guidelines. Because the databases used for CTSFF have some limitations regarding the patients included and the data elements that are included, that document and this presentation are supplemented by information from some other sources. One other limitation is the amount of time I have, which is now about 8.5 minutes. The surgical options for breast cancer are breast-conserving surgery or mastectomy. Axillary lymph nodes are often removed by sentinel lymph node biopsy or by axillary dissection to check for the spread of cancer. Treatment may also include radiation therapy, chemotherapy, hormonal therapy, and targeted therapies individually and in various combinations. In most cases, survival outcomes are equivalent for breast-conserving surgery plus radiation therapy or with mastectomy. Some patients require mastectomy for medical reasons, and some prefer mastectomy for personal reasons. Also, for most women, sentinel lymph node biopsies and axillary dissection have equal benefits, and the sentinel lymph node biopsy has less risk of lymphedema, a swelling of the arm on the same side as the treated breast, which can cause pain, swelling, and disability. 5-year relative survival is best with localized disease and much worse with distant spread. Compared with white women, African American women have lower proportions surviving within all stages. Breast cancer is notorious for late recurrences, and survival continues to decline between 10 and 15 years after diagnosis. This chart illustrates the percentages of women with breast cancer receiving various treatments. There are far more combinations than we have time to discuss today, but I definitely want you to see the green bars in this bar chart. These represent women who did not have any surgery, chemotherapy, or radiation. In some cases, this decision may be appropriate because of other serious health problems, but this graph still raises the question of whether some patients are not getting treated at all, and why. And who are these women? One also wonders about the women represented by the light blue bars who had breast-conserving surgery but no radiation therapy. And we'd also like to know whether women who undergo mastectomy are having this operation for the right reasons. This graph raises as many questions as it answers, which is actually great because there are ways to find out many of these answers. Let's briefly consider 2 studies that found answers to some of these questions. And if you look at the fine print, you should recognize the names of some of these researchers. In the first study, a nationwide review of treatment patterns showed that black women were less likely than white women to be treated appropriately for loco-regional disease with surgery or surgery plus radiation. Black women were also less likely to be treated with hormonal therapy and with chemotherapy as they should have been. The second study focuses on women with breast cancer in the Atlanta metropolitan area and found substantial racial disparities in the percentages of women who did not receive appropriate surgery or radiation. Some very early stage colorectal cancers can be treated by removing a polyp that contains a small area of cancer. Most colorectal cancer surgery involves removing the part of the colon or rectum containing the tumor, or if the tumor is in the part of the rectum next to the colon, then parts of both the colon and rectum may be removed. A colostomy is needed more often for rectal cancer than with colon cancer, and in some cases, it may be temporary with a second operation later on to reconnect the ends of the bowel back together. Patients with stage 3 colon cancer and some with stage 2 cancer have adjuvant chemotherapy given before surgery. For stage 2 and 3 rectal cancer, neoadjuvant chemotherapy and radiation are usually given before surgery. Chemotherapy and targeted therapies are the main treatments for advanced cancers of the colon and rectum. As with the breast cancer chart, there are a lot of treatment combinations, but at least 2 concern me. The light blue bar for stage 3 colon cancer, representing patients who had surgery but not the chemotherapy that is generally recommended, and the light green bar for patients with stage 4 colon cancer who did not have any surgery, radiation, or chemotherapy. So one wonders whether some colon cancer patients are not getting the recommended treatment. Why not, and who they are. This slide summarizes a study of the extent to which treatment recommendations are followed based on guidelines from the National Comprehensive Cancer Network, or NCCN. As we expected, some patients with stage 3 and stage 4 colon cancer are not getting the recommended treatments. And that percentage is even larger for stage 2 patients. Furthermore, older patients are less likely to be treated according to guidelines. Some of these older patients may be too frail to tolerate standard treatments, but several other studies have found that undertreatment is not uncommon among relatively healthy patients even in their 70s. This study also noted that patients lacking private insurance were less likely to receive recommended treatments. On the other hand, some young, healthy patients with early-stage colon cancer received chemotherapy that the NCCN expert panel considers to be unnecessary. This graph from CTSFF shows that about 90% of patients with localized colorectal cancer survive 5 years, but the prognosis is less favorable with regional spread, and only 13% of those with distant spread survive 5 years after diagnosis. It also documents the racial disparity in survival and the decline in survival during the first 10 years after diagnosis. The two main types of lung cancer are treated very differently. Patients with small cell lung cancer usually receive chemotherapy with or without radiation. Most patients with early-stage non-small cell lung cancer undergo surgery, and some also receive chemotherapy and or radiation. Advanced non-small cell lung cancer is generally treated with chemotherapy and or targeted therapies. This bar graph from CTSFF shows several important points about treatment patterns for non-small cell lung cancer. But again, in the interest of time, let's focus on one bar, the green one, for patients with early-stage disease who are not treated by surgery, radiation therapy, or chemotherapy. In this summary of an interesting American Cancer Society study, we see yet another factor contributing to treatment disparities. Patients treated at high safety net burden facilities, having a high proportion of oncology patients who are uninsured or covered by Medicaid, were substantially less likely to undergo potentially curative surgery. This graph from CTSFF shows the serious prognosis for lung cancer, even when disease is apparently localized at the time of diagnosis, and the even more dismal outlook for patients diagnosed with distant stage disease. In summary, I'd like to emphasize the importance of studying survival and treatment patterns and identifying opportunities for quality improvement, and in recognizing disparities associated with patient demographic factors and treatment facility characteristics. I've had time to discuss only 4 cancer types today: breast, colon, rectum, and lung. And this slide lists the other 8 types that are also addressed in CTSFF. And finally, with a few seconds of my time remaining, it's a pleasure for me to introduce Dr. Kevin Stein, who will be discussing long-term and late effects and other important survivorship topics.
Thanks, Ted. I will now address some of the issues that cancer survivors face with respect to achieving and maintaining a good quality of life and a healthy lifestyle. As discussed in several places in this report, many systems of the body are affected by cancer and its treatment, which can result in a wide range of symptoms and side effects. You can see many of the symptoms and systems affected and the associated side effects listed here in this slide. As you can see, the side effects range from physical issues, such as cardiotoxicity and bone fractures, to emotional and mental problems, such as anxiety, depression, and problems with memory and concentration. In the next few slides, I will focus in on the 3 most common problems that survivors report: pain, fatigue, and fear of cancer recurrence. Starting off with cancer-related pain. Cancer-related pain is very common. Studies indicate that 2 out of 3 cancer patients experience pain at some point during their cancer journey. And as we all know, being in pain is extremely distressing. It can lead to depressed mood, impacts activity levels and relationships, and can have a negative impact on overall quality of life. In fact, pain is cited as the most feared symptom of cancer and its treatment. Despite being very common and distressing, cancer pain is not well understood, partly because its causes are multifactorial. I will not review the many causes of cancer pain in the interest of time, but suffice it to say that cancer pain can be related to the disease process itself, but can also be related to the toxicities of cancer treatments. Also unfortunate is the fact that pain is not routinely or assessed and is often poorly managed. Pain can be adequately managed if properly identified and treated. As noted on the slide, adequately controlled cancer pain is an important part of quality cancer care. Turning now to cancer-related fatigue. Cancer-related fatigue is a persistent, ongoing feeling of tiredness or lack of energy. Unlike normal tiredness or exhaustion that we all experience from time to time, cancer-related fatigue is typically not relieved by sleep or rest. Cancer-related fatigue is also multidimensional in nature. That means it can manifest in several different ways as different types of symptoms. For example, in the physical domain, cancer-related fatigue may manifest as aches and pains. In the emotional domain, fatigue may look and feel like depression. In the behavioral domain, fatigue is often expressed as low energy and an inability to get things done. And in the cognitive or mental domain, cancer-related fatigue can lead to problems with concentration and memory. Unlike pain, there are no well-established treatments for the management of cancer-related fatigue, so it represents a significant clinical challenge. However, there are some studies that suggest that exercise interventions can be effective in relieving cancer-related fatigue. Now, looking at fear of cancer recurrence, it should be stated that it is normal to have concerns that your cancer may come back. However, fear of cancer recurrence becomes problematic when it leads to extremely elevated levels of anxiety that can interfere with one's ability to function normally in their day-to-day social and work-related activities. Fear of cancer recurrence may always be present at a low grade, but can also be episodic in that certain events or reminders can trigger it to spike and become a problem. For example, the days and weeks leading up to a meeting with one's oncologist for an annual visit or routine cancer screening are oftentimes of increased fear of cancer recurrence. Likewise, survivors may interpret aches and pains as signs of metastatic disease, triggering heightened fear of cancer recurrence. Even just being asked about your cancer or seeing something on TV can trigger anxiety about cancer recurrence. Management of fear of cancer recurrence can be achieved through pharmacological treatments, such as anti-anxiety medications, as well as non-pharmacological interventions, such as stress management, meditation, yoga, and deep breathing exercises. It is worthwhile to differentiate between long-term and late effects. Specifically, long-term effects are those problems that typically develop during cancer treatment and stay with the individual for months or even years. Examples of long-term effects include pain, fatigue, sexual problems, emotional problems, and neuropathy. In contrast, late effects are those problems that typically are not present during or immediately after cancer treatment is completed. In fact, they may not surface until many years have passed. Late effects tend to be more of a medical nature, such as cardiotoxicities or osteoporosis, although emotional concerns can develop years later as well. It is also worth pointing out that not all outcomes of the cancer experience are negative. In fact, many cancer survivors report positive outcomes, often referred to as benefit finding or post-traumatic growth, which can take the form of a new appreciation for life and improved relationships with family, friends, and coworkers. We will now turn our attention towards long-term survivorship issues. There have been several reports issued by the Institutes of Medicine that have addressed the issues of post-treatment cancer survivors. You see two of them here. The first, From Cancer Patient to Cancer Survivor, addresses the challenging time of transitioning from being an on-treatment cancer patient under the care of an oncology team to being an off-treatment, disease-free cancer survivor who is going back to the care of the primary care doctor or general practitioner. This fragmentation of care and management of cancer-related problems can be quite problematic for some survivors. The other report, Cancer Care for the Whole Patient, addresses the need to attend to both medical and psychosocial needs of cancer survivors. Adequate symptom management should be provided alongside primary cancer treatment aimed at curing the cancer itself. Both of these reports address the need for adequate post-treatment survivorship care. One of the tools we have at our disposal for providing optimal post-treatment care is called the Survivorship Care Plan. The Survivorship Care Plan is a written and, if possible, electronic document that puts down in writing a plan for the survivor's care after primary treatment is completed. It includes a detailed summary of the treatments the individual received and the medical and psychosocial risk factors associated with those treatments. It should be provided by the oncology team to the survivor upon the completion of treatment. Ideally, it should also be shared with other members of the survivor's healthcare team, including their primary care doctor, as well as other cancer specialists they may be seeing, so that all members of their care team are fully informed. The survivorship care plan should include a plan for surveillance tests for the incident cancer to check for recurrence, as well as monitoring for other long-term and late effects. The survivorship care plan also addresses lifestyle and preventive behaviors, such as compliance with diet, physical activity, weight management, and cancer screening recommendations. That last point is a great lead-in into the final issue I will address, regaining and improving health through healthy behaviors. We know that cancer survivors are at greater risk for second cancers and other comorbid conditions, including late effects of treatment. A healthy lifestyle is associated with improved health and reduced risk of a number of health problems. As a result, survivors are often encouraged to make healthy lifestyle changes after completion of treatment. A number of organizations have issued guidelines for healthy living, including the American College of Sports Medicine and the American Cancer Society. Here you see the American Cancer Society Nutrition and Physical Activity Guidelines for cancer survivors. The first recommendation is to achieve and maintain a healthy weight by attempting to balance energy taken in with energy expended to promote good weight management. The second is to engage in regular physical activity, avoid inactivity, and return to normal daily activities as soon as possible following cancer diagnosis. Aim to exercise for at least 150 minutes per week and include strength training exercises at least 2 days per week. And the third recommendation is to achieve a dietary pattern that emphasizes plant foods, including vegetables, fruits, and whole grains. Eat a variety of healthy foods with an emphasis on plant sources, limiting consumption of red meat, especially processed meats, and those high in fat. In addition to the problems that survivors face, we should keep in mind that cancer affects the whole family, including informal caregivers and other members of the family. A paper published by the American Cancer Society's Behavioral Research Center revealed that caregivers report a variety of persistent unmet needs. As shown in this figure, caregivers' psychosocial needs are primarily centered on their ability to help the survivor deal with their emotional distress and find meaning in the cancer experience. Ongoing medical needs include obtaining information about the cancer, its treatment, and side effects, and obtaining the best possible care for the survivor. Issues related to the caregiver's daily life, including their ability to balance their own personal care with the demands of caregiving, seem to be most affected within 2 years of diagnosis. Not surprisingly, caregivers feel overwhelmed by these care demands and the high expectations they set for themselves in providing care. While juggling multiple care demands, caregivers also have to deal with their own physical health issues. Additional research has explored the time demands and financial burden that cancer caregivers experience. These authors found that even at 2 years after the cancer diagnosis, cancer caregivers were still spending an average of 8 hours a day providing care, with the highest time costs associated with providing care for lung cancer patients, as shown in the figure on this slide. With a myriad of cancer task responsibilities, including gathering information to advise treatment decisions, attending to treatment side effects, coordinating medical care, managing financial issues, and providing emotional support to survivors, caregivers' own quality of life may suffer. Finally, I will address some resources that are available to cancer survivors, their caregivers, and their healthcare providers. As you can see, there are many organizations that provide resources for cancer survivors and their loved ones. The National Cancer Survivorship Resource Center, or Survivorship Center for short, is a collaboration between the American Cancer Society and the George Washington Cancer Institute, funded through a cooperative agreement with the Center for Disease Control. Here is a screenshot of the Survivorship Center, and the web page listed on this slide is where you can find more information and resources. You see a number of the products of the Survivorship Center. All of these resources are available at the website listed at the bottom of this slide. The first three in red are resources for patients and survivors, including dedicated survivorship web pages, a life after treatment guide, and a chronic disease self-management program. The last four are resources for providers. I'll spend a little extra time on the last one, Survivorship Care Guidelines for Primary Care Providers. One of the major activities of the Survivorship Center is the production of Survivorship Care Guidelines for Primary Care Providers. Other groups are producing guidelines, including ASCO and NCCN, but they are either focused on management of specific side effects or targeted towards oncologists, whereas ours are disease-specific and aimed at primary care providers. See here the first overall paper, which sets the stage. It was published this past year in CA. And the prostate cancer guidelines just came out, and more will follow.
Thank you so much. And I do just want to take a minute to thank all of the many people that contributed to this report, both inside the society as well as externally.